Hi, my name's Jenna Evans, and I'm a member of the coding education team and work specifically with the IM Specialties Pod, of which gastroenterology falls under. I have 30 years of experience in medical records, or the fancy name health information management, and I always tell providers that documentation is your best friend. Accurately documenting the care provided supports your coding and billing, and just as important, it is your best friend if you ever have a lawsuit and find yourself in court. So take time to assess your documentation skills, and if you have questions, myself or another member of the coding education team can help you. So as you're aware, we've made it through the first year with ICD10. On October 1, we'll have coding updates for I-10 go into effect. And so now as we prepare for this, what can you do as a provider to help us? So, as you know, for this first year, Medicaid has not accepted unspecified codes. We are expecting come October 1 that Medicare will also lift their grace period, and they will be looking for more specific information in your coding. So as we get close to that, you really need to think about documenting the highest level of specificity that you can. You really want to steer away from the codes that say unspecified. Anything you can do to try to select a code that's a higher degree specificity would help you. Granted, there are times that you may not have diagnosed something and you have to use the unspecified, and that's going to happen, but that should not be the norm. We should use that as the rare exception. So other things that you can do to help, like I mentioned, you can actually help us by documenting to the highest level of specificity. Keep in mind that if you have not diagnosed something and it's still a sign or symptom, probable or suspected, use that sign or symptom. You can't actually code the definitive diagnosis until you actually can document that in the record. Do you have any diagnoses that have a cause and effect relationship in the code book? You might want to make sure you put both of those in. Document all of that. Also link your complications to chronic conditions. There are some codes in I-9 that were one code and are now two codes in I-10, or perhaps even the reverse. We have seen some changes. So again, the more you can document and help us and give us information in the record, that's going to help you also. Also, most important is when you're dictating your note, please make sure you address any diagnoses in your impression and plan. If you assessed or treated them, it's important that you document and get credit for that, and provide clear diagnoses for us and actually code those when you code your note. And lastly, as many of you are aware, within EMR we have a problem list. Make sure you look at that problem list. It tends to get a little full of some things that perhaps are no longer valid, or somebody added and didn't realize they did add. So specifically for gastroenterology, you might want to look at that problem list, and it's something you've added, and if it's no longer active, you can make it inactive or add new diagnoses as you have them for your patients. So let's jump right in and look and see what are our new changes for Chapter 11, Diseases of the Digestive System. First, right off the bat, in the category of other and unspecified non-infective gastroenteritis and colitis, they've actually broken down the category of allergic and dietetic gastroenteritis and colitis to give you three other options in that category: food protein-induced enterocolitis syndrome, food protein-induced enteropathy, or other allergic and dietetic gastroenteritis and colitis. So if you want to make sure you document very specifically for one of those, if it fits the bill for that, that would help you there. Also, they've also added a subcategory for indeterminate colitis. Also new this year, we've seen have expanded the category of microscopic colitis with a further addition and specification with a 6th digit. So now you can be very specific and talk about collagenous colitis, lymphocytic colitis, other microscopic colitis, or microscopic colitis unspecified. And as I previously mentioned, those codes that end with unspecified, those should be your exception rather than the norm when you're documenting. So here, as we get into this category, the acute vascular disorders of the intestine, we now see that it's further subdivided into several categories. So at the top of the slide, you see the 6 bullets that have the sites, the ischemia and infarction of the small intestine, the large intestine, and the intestine with the part unspecified. So for each of those, if you look at the 3 bullets at the bottom of the slide, you can see that you can now add a 6th digit. So you could have acute ischemia of the small intestine that has the focal segmental acute reversible, or the diffuse acute reversible, or the acute reversible extent unspecified. And those are all differentiated by adding that 6th digit of either a 1, 2, or 9 on the end of your code. Also new this year, they've broken down the necrotizing enterocolitis, which can now be further specified. First off the bat, they do have the unspecified code, and then you can also break it down by stages, stage 1, stage 2, or stage 3. And I'll continue to reiterate, obviously trying to specify a stage, if you've been able to diagnose it that specifically, that is much more definitely the choice than choosing that unspecified code. Also, a few new categories for the irritable bowel syndrome. Irritable bowel syndrome with constipation, mixed irritable bowel syndrome, or other irritable bowel syndrome. Those are all, the subcategory for the irritable bowel syndrome was K58, and those are all 4th digits now added on there to help you. Also, they've further added down for constipation. You now have drug-induced constipation and chronic idiopathic constipation. And if you do know that it's an adverse effect from a drug, then you'd also use a code to identify the drug and add that in. So you'd have 2 codes if you have the drug-induced constipation and identify the drug if possible for the adverse effect. They've also deleted the megacolon not elsewhere classified code and been more specific of adding toxic megacolon and other megacolon. Another area where they've further expanded what you have is the codes for acute pancreatitis. You'll see the 6 bullets at the top of the slide, the idiopathic acute pancreatitis, biliary acute pancreatitis, alcohol-induced acute pancreatitis, drug-induced acute pancreatitis, other acute pancreatitis, and acute pancreatitis unspecified. You can now further break that down and add a 5th digit to those above codes without necrosis or infection, with uninfected necrosis, or with infected necrosis. So all of those you would use that 0, 1, or 2 on the end of your codes. Also, they've had a breakdown for codes for other specified diseases of the pancreas. You now have options for exocrine pancreatic insufficiency, as well as other specified diseases of the pancreas. Also, there's further breakdown for malabsorption due to intolerance. Those include non-celiac gluten sensitivity and malabsorption due to intolerance, not elsewhere classified. We also have a few revisions in this code section, and you'll see this theme recurring throughout many of the chapters in I-10. They've done a lot with the post-procedural hemorrhage and hematoma codes for this new release coming up October 1. So for this particular slide, you'll see on both bullets that the "and hematoma" has been removed. So this code is specifically relating to post-procedural hemorrhage, whether it's following a digestive system procedure or following another procedure. And as we move here to the next slide, you'll see that they've actually pulled the hematomas out. While they did revise the previous code, they've made these into their own codes. The post-procedural hematomas of the digestive system organ or structure following either a digestive system procedure or another procedure. And you'll also see at the bottom, they've also added codes for post-procedural seromas of the digestive system, whether it's following a digestive system procedure or another procedure. One of the other chapters that does have a few things that touch on gastroenterology and the digestive system is the Chapter 2 neoplasms. They've also broken down the gastrointestinal stromal tumors by site. And here you would be very specific for the location. Is it the esophagus, the stomach, the small intestine, large intestine, rectum, or other sites, or our least favorite choice, the unspecified site? There might be a time that you're seeing a patient for the first time and you're doing a workup, so the unspecified site might be what you have to choose, but hopefully after you'd seen the patient, you would be able to be very specific in your documentation on that. And those are actually fifth-digit codes that would specify the esophagus and the other bullets there that you would add on to the other code. There are a few other new codes that I do just want to highlight that you would probably use throughout your practice, and that back in the world of I-9, we had a code specifically for prediabetes, but in the world of I-10 last October, they really classified all that under abnormal glucose, which was an R73.09 code. This year for October 1, they've actually brought back a code specifically for prediabetes, R73.03. So you have that differentiation now. Also, when I-10 came out, they were very big on only having one code for hypertension, I-10. That was the code for the essential primary hypertension. They've now added 3 new codes to help you be more specific, and a lot of these might be more specific to cardiology, but I did want to share them to let you know you have these options. There's hypertensive urgency, hypertensive emergency, and the hypertensive crisis unspecified. And those all fall into an I-16 category. So the basic hypertension is I-10, what we've all come to know in the past year, and these other 3 new additions are in the I-16 category and differentiated by their 4th digit. A couple of other codes. We've had the long-term current drug therapy code. New this year, they've added a long-term current use of oral hypoglycemic drugs that also has underneath it the long-term current use of oral anti-diabetic drugs. Keep in mind that if you were to use this code, you'll see that it does have an excludes to note, and it means that you can also code the long-term current use of insulin. So if they were on both of those, you could use both of those codes there. So in closing, I do just want to share my contact information with you. I can be reached via my email or my desk number. Feel free to contact me if I can further help you with some of this information, or if I can help you with your documentation. I'm always just a phone call away. Thank you so much for taking the time to watch our webinar today.